Good evening. My name is Dr. David Doman, and welcome to another edition of House Call. Our topic tonight is podiatric medicine. My guest this evening is Dr. Adam Spector, a noted podiatrist practicing here in Montgomery County. Dr. Spector, welcome to House Call.
Thank you very much. Happy to be here.
So briefly, tell our viewers about your professional background.
So I'm a podiatrist, doctor of podiatric medicine, 4 years of college at GW, 4 years of podiatry school in Temple, and a residency program, and then I'm back here practicing.
Very nice. And where do you practice?
So I practice in Silver Spring, Wheaton area, and also in Rockville. Part of I have my own offices, but I'm part of a larger group, our foot and ankle specialists of the Mid-Atlantic, a group that continues to grow. We have 70 doctors and through down to North Carolina, DC, Virginia. So big group, but small town type of feel for our practice.
Very nice. What exactly is a podiatrist? Explain to our viewers.
So podiatry is the medical and surgical treatment of all foot and ankle issues, and the boundary for surgery is below the knee, and there's a lot of overlap. We see skin, nail, bone, tissue, tendon issues. And we treat, we prescribe medicines, we admit people to the hospital, we do surgery. I have my own surgery center in our Wheaton office. We treat local problems, but we certainly take everything into account.
Why did you choose podiatry as opposed to other areas of healthcare?
So my father is a physician, I always knew I was going to be a doctor. I did grand rounds with him when I was 6,
Wow.
going all across. And through him, I met all of his colleagues. He was an oncologist, hematologist, but I was with dermatologists and orthopedics. And it turns out one of his best friends was a podiatrist who really mentored me and kind of pushed me in that direction. I think what I liked about it was a lot of medical thinking and diagnosing, and then also a lot of hands-on, a lot of surgical things to do.
So a nice blend.
Yeah, I really enjoyed the mix of it.
Very nice. What kind of problems fall within the realm of podiatry?
So, like I said, there's a lot of, pretty much territorially, anything below the knee.
Yeah.
But, there's a laundry list from injuries, tendinitis, heel pain, simple things like ingrown nails, and pretty much everything in between, So it's a broad field, even though we are specialists.
Sure. You mentioned heel pain, and as you know, that's a very common complaint. Explain to our viewers, first of all, what are some of the causes of recurrent or chronic heel pain?
So, in this era of Google, everything is, you can Google something and there's a lot of plantar fasciitis out there.
Define for our viewers what is plantar fasciitis.
So plantar fasciitis refers to pain usually on the bottom of the heel or arch. It's typically an overuse type injury where you can have muscle, tendon, ligament type pain in the arch and also on the heel. It's usually worse in the morning. And it's very common when people, especially now when people aren't wearing supportive shoes, people are exercising. Some of the fashion statements with some of the lightweight neutral shoes, the barefoot running, a lot of that lends itself to developing plantar fasciitis. But there's an awful lot of other things that can cause heel pain too. Nerve pain, foreign bodies people step on, certain systemic things like gout, certain arthritic issues can cause heel pain, and there are stress fractures and cysts that grow. So, so sometimes I mean, going back to the Google Internet thing, we tell people if things aren't getting better in a pretty reasonable time and you've tried simple things, coming in for x-rays, for evaluation, it's pretty important.
So if somebody does come in with chronic heel pain, how do you evaluate them?
Clinically, when you examine somebody, you can narrow it down pretty well. I think I pretty much figure out what's wrong just by listening in the first 3 or 4 minutes.
Yeah.
But certainly putting my hands and examining and seeing exactly where the pain's coming from, and using modalities that I have in the office, my x-ray machine, ultrasound, sending and referring out to MRIs and other things if I need it. Sometimes blood work too, to come down to an accurate diagnosis.
And you actually sometimes do find foreign bodies that by retrieving it, the heel pain goes away?
Absolutely, yeah.
They step on glass or something they're not aware of? Or
Yeah, I've been in practice 28 years, and
Yeah.
I've seen diabetics step on insulin needles.
Sure.
I've seen glass that kind of worked its way in.
Yeah.
I've seen people that cut hair for a living where some hair worked its way in and
Really? Yeah.
caused, so yeah, I think, it's not all plantar fasciitis.
Yeah.
Seeing a doctor is definitely to your advantage.
So given that there are some patients at least who have plantar fasciitis, how do you treat that?
So plantar fasciitis is predominantly an overuse type thing. So we want to get rid of the acute pain, either with anti-inflammatory medicine, physical therapy, sometimes cortisone injections. And then we want to treat long-term with better support. So it could be shoe gear, it could also be over-the-counter arch supports, or sometimes prescription arch supports to.
And by arch support, you mean orthotics? Right, okay.
Well, there's different types of arch supports. There's over-the-counter arch supports, and sometimes that works great.
Yeah.
There's Dr. Scholl's, there's all the ones in the running stores. And so for somebody that doesn't have a super serious issue, that has maybe minimal, moderate activity, that doesn't really have a foot deformity structurally, then over-the-counter ones work great. And for some people with more serious deformities, the prescription ones work a lot better.
Okay.
I use the analogy of the CVS reading glasses with the over-the-counter ones versus having your prescription glasses.
Sure. And what do you do when you have somebody who, for example, is a runner, maybe just for joy, or you have a professional athlete who develops plantar fasciitis? What do you tell them in terms of reasonable recovery? Can they resume running? Can a pro athlete resume his career?
So, I'm of the ilk where I have to exercise every day, or my office personnel staff, they don't want to work with me. And I know you exercise regularly at lunch, and it's so important to keeping us going. And so I think being athletic, I'm of that mindset where I want to get people better with missing a minimal amount of time.
Sure.
I see every day people come in and they're coming from somewhere else, and they've been immobilized, and it doesn't really fix our problem.
Yeah.
So everything we do is designed to get people up and keep them mobile and minimum of downtime.
Why do orthotics help heel pain?
So heel pain, even when it's in the very bottom of the heel, it's caused by the traction or the pull of the plantar fascia on that bone. Some people get bone spurs as a result, but it's not the bone spur that hurts, it's the actual pulling of the muscle. So if we can support the muscle with an arch support, we can really control the biomechanics, we can control how much that's hurting them.
So it's really kind of like a splint.
Yeah, I would put it in the brace category.
Yeah,
it's really like a brace that stabilizes your foot and prevents that muscle from being overused.
Once somebody is prescribed orthotics and they hopefully respond, do you recommend they use it indefinitely or just for a therapeutic trial for a few weeks, months?
I think all of the above. I have orthotics, and for me, it's an ounce of prevention. I think I don't want to get hurt. I don't want to miss time. And some people feel the same way. Some people, it's such a dramatic difference that they always want to have them on or in their shoe. And then there are others where they do just need it for that acute period, or they may only use it when they work out. They may not use it all day long. But if they're a benefit, it seems that if it's a beneficial sometime, the more you use it, the more you'd benefit, I would think.
Sure. When should a viewer, if they're having heel pain, embark upon an over-the-counter orthotic, or when should they say, no, that's a waste of time and money, and I should get a custom-made orthotic?
Well, I think it's great to always try the simple things first. So even in the office, I have different over-the-counter arch supports that I offer people, and there's nothing wrong with trying them. I think the key is I always hear people, they come in and they say they've had this heel pain for 6 months. Well, what have they done for 6 months? I think if the over-the-counter arch support is not sufficient within, I'd say, a couple weeks at most, that's the time to look further. And again, the orthotic is only a part of treatment. It's not it's just there's a lot of different facets of the heel pain that we want to address.
If somebody goes to buy an orthotic, you mentioned Dr. Scholl's or any of these over-the-counter options, there are more than one option when you go shopping. So how does one choose, how do they know what is the right option for them?
I mean, Dr. Scholl's has this fitting, but it doesn't compare. Again, it's still an over-the-counter. It doesn't compare to your prescription glasses.
Sure.
It is like a reading glass. So it really is trial and error. I think there's a Superfeet brand. There's all different brands, and I think some of the over-the-counter ones are just trying out different ones and seeing what works. And if it works and it relieves your pain, then that's great. But again, we don't want it to drag on and on. If people are still having pain, that's the good time to follow up.
Sure. You mentioned earlier gout. How often are you encountering that in a podiatric practice?
So it's interesting. A lot of people come in with something that they think is an isolated foot problem, and it really is indicative of something much greater. And so I have patients that come in with what looks like a pain at that big toe joint. Maybe they think it's just general arthritis, or they think it's a bunion deformity. And gout, if you've seen it, I know it has a very distinct bright red, swollen, hypersensitive, hyper-painful presentation. And it's important to know that, to be able to differentiate that, because if you have gout in your foot, you may have it somewhere else also. You probably do, and it may require further workup. And that goes for a lot of things. I see people with a nail deformity, which may be indicative of someone with psoriasis. And sometimes I ask the questions, and it turns out they do have a rash.
Right.
And then I send them for evaluation. It turns out they do have some arthritic joints. And same with someone with diabetes, for instance. Somebody might come in with a sore on their foot, and by virtue of the fact that maybe it's not healing very well, or that they're insensate, it may tell me that they should be worked up for diabetes. So there's I see a lot of things that manifest in the foot that over the years you become very astute and aware of what's happening.
Very good answer.
Thank you.
We're going to pause briefly for a public service announcement. More with our guest, Dr. Adam Spector, a noted podiatrist here in Montgomery County, in a moment. We'll be right back.
150 over 90.
180 over 111.
160 over 110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it, or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
We're back. My guest this evening is Dr. Adam Spector, a podiatrist practicing right here in Montgomery County. Dr. Spector, let's go on to discuss diabetic foot care. That's a major topic, as you know, in Montgomery County, as well as it is nationally. And indeed, as you all know, it's a major cause of even amputation in the most extreme cases. So take our viewers through what exactly is diabetic foot, how the many manifestations, how you evaluate it, and the different treatment options. So
diabetes is a very serious disease, and it takes a healthcare team, really. And what I alluded to earlier was sometimes I'm on the front line of that team. Some people come in and they don't even know they have that diagnosis of diabetes yet. And I may be the first one who sees them with a significant complication of it. And really, anybody who's diabetic, if you do know, you should be checked by multiple specialists, but especially a podiatrist, yearly. And people who do have problems, we have them come in every 6 months or 3 months, because the name of the game is prevention. Our group, our foot and ankle specialists of the Mid-Atlantic, we have a diabetic wound care specialist we've employed, who deals with all problematic wounds. And we have a limb salvage center also, where the whole goal is to prevent any infection or anything from becoming a problem. Diabetes is a problem where over time it affects circulation, it affects their ability to feel problems.
So the nerves may be damaged.
So there's nerve damage called neuropathy typically. There's vascular issues. There are structural issues too, and a lot of it is designed. A lot of our treatments designed to prevent problems with evaluating them and teaching patients how to evaluate them and educating them and getting them into the proper shoes.
Right.
And a lot of it is routine care, treating their nails and making sure that if they do develop an infection, we're quickly, dealing with it. And then of course they have internists, endocrinologists, and we make sure that those diabetics are really well taken care of.
I would imagine one of the challenges for you, and by extension these patients, is that when they do have nerve damage and their sensation is impaired, they could have a significant problem with their foot and not even be aware of it.
Yeah, it's a challenge. You and I have a certain biofeedback mechanism where if we step on or if there's a step on something or there's a loose pebble in our shoe, we'll be aware of it right away. And I have a lot of stories of people who don't have great sensation and develop serious problems because they didn't feel it right away and they kept walking on that pebble, or their foot got near a heater that was too hot and they couldn't feel it. And it really is a challenge. It's a very difficult disease to deal with.
Somebody comes in then with a foot infection. What kind of testing do you get?
So our group now, our foot and ankle specialists at Mid-Atlantic, we have our own pathology system, our own pathology lab, and so we know that knowing exactly how to treat people when they do have an ulcer, we culture it. We can biopsy certain things. We can focus and streamline our treatment so that we're very efficient with our choice of antibiotics or topical medicines. People that have long-standing ulcers, there is a possibility that they can develop infections that penetrate deep into the bone, and we utilize X-rays and MRIs, and we use all of our resources to make sure that these problems don't get too bad.
What do you do with a diabetic foot when there's an infection and it's no longer soft tissue and has penetrated the bone, osteomyelitis?
So a lot of that does happen, and our focus is preventing that in the first place. But when it does happen, the treatment can vary from long-term IV antibiotics to excising, removing surgically that infected bone. Ultimately, that really is the only way to eradicate the infection of a bone. We don't work in a silo. We have vascular specialists and neurologists, and it's not enough to do surgery on those patients. You also have to make sure that they have the ability to heal and that their circulation's good, and often they need bypasses or other medicine to make them better surgical candidates or better patients to heal.
So a vascular specialist may do something to improve the blood flow to the foot.
Yes.
Okay. you ever use hyperbaric oxygen?
Hyperbaric seems to, popularity seems to go up and down, and sometimes it's whether or not the insurances will pay for it. It was very popular when Michael Jackson was getting in the body chamber.
But not for therapeutic reasons.
He did it, I
Yeah.
think, maybe to look younger, I don't
Yeah,
know.
yeah.
But there
And
are...
explain to our viewers what exactly is hyperbaric oxygen.
So hyperbaric oxygen is one of the many things that we use to treat an ulcer, and typically somebody that has a deep infection, anaerobic bacteria, the wound is just pummeled with oxygen, and it sometimes will kind of clean out the wound better than other things. But we have so many other options at our disposal. We have wound vacs, which is actually something that just pulls out fluid and lets things close. And the different types of wound dressings now are so sophisticated. We can tailor it to exactly what the wound looks like at every stage. So there's a lot of things at our disposal that we can do. It's not just putting Neosporin and a Band-Aid on it. You know?
Right. Which leads me to the next question. When you give antibiotics, do you give it directly on the wound? Do you give it by pill, or do you give it by IV, or do you give some combination?
I mean, it depends. There's a lot of different scenarios, so it does depend. Nowadays a lot of things are outpatient. So IV antibiotics we can do outpatient. Topical antibiotics, there is some use for that. Oral antibiotics are also effective. Some of our oral antibiotics are just as effective as in an oral versus an IV form. So yeah, I mean, all types of antibiotics play a role. But there's also the role of superinfections and antibiotic resistance, and so we use them judiciously. There's a lot of other things we can use too.
Let's shift gears then to discuss another common problem you deal in podiatric medicine, which is toenail issues, both in terms of ingrown nails and a very important topic, which is fungal infections. Let's first of all discuss ingrown toenails, which can be very uncomfortable, as you know. How do you address that?
So ingrown toenails, I see it every day, and I see a lot of children in my practice. I enjoy seeing the kids and hopefully demystifying the whole doctor scenario and making them not so scared about it. But mild ingrown nails can respond to topical antibiotics, the old school warm water, Epsom salt, and soaks.
Yeah.
And more serious ones, we commonly will numb the toe and remove the offending nail border. Sometimes an ingrown nail, I describe it as a foreign body. It's something that is in the skin and not allowing the infection to drain and come out. So sometimes addressing it is the way to kind of fix it permanently. And there's a lot of different procedures we use for that.
Sure. And then what about fungal infections where it's growing underneath the nail bed?
So fungal infections are something we see a lot of, especially as people start to put on their sandals when the warm weather. And it's a difficult problem. I mean, it's not just a cosmetic problem for some. The nails can become very thick and uncomfortable and ingrown. Yeah. So it does necessitate a lot of treatment. And we usually will culture it. Again, we want to know what we're treating. There's other things that may cause, it could be a yeast or a saprophyte or a bacteria or psoriasis, like we mentioned. So once we're sure of our diagnosis, there are topical medicines we can use that will treat the appropriate whatever it is, and there's lasers that we use which are effective, and there's also oral medications. So we use them all depending on the person and their needs and the chance of success.
When you use laser, how exactly are you getting laser to attack an infection underneath the nail bed?
So there's really there's a lot of lasers out there, and I see them advertised on Groupons, but really there's only two that are effective, and they are effective because they penetrate through the nail into the nail bed, and they they destroy the fungus that lies there, so that as the new nail grows in over the course of 3 months, which is a normal nail cycle, the nail can be normal.
So you wipe out the nail when you wipe out the infection, at least temporarily.
Yeah, the nail is still physically there.
Yeah.
It just slowly grows out normally.
Okay. And do you ever need to surgically intervene, remove a nail bed to clean up the underlying infection?
I have at times. I think that there are better options. I think we want to keep people active, and it's not always necessary to remove a nail unless it's a traumatic nail where the nail is damaged somehow, and it's the only one on their foot. So many people, and when it's a true fungus, there's multiple nail involvement.
Yeah.
So removing multiple nails seems to be really unnecessary.
Sure. Let's go on to discuss barefoot running. I like to run. I know you like to work out. And that's a hot new craze now. What is the rationale for barefoot running?
So I do a running clinic that we started with the Montgomery County Roadrunners. Started it. It's a lesson in volunteerism. I thought it was going to be a one-time thing, and it's been every month for the last 20 years. And we see runners run on a treadmill. It's multidisciplinary with coaches and physical therapists and shoe people. It's called the Run Performance Lab. And it's very interesting to see different people run in different types of shoes. And there is a place for some of these neutral, cushioned, or barefoot type running shoes, or no shoes.
Yeah.
There's a lot to be learned. We talk about cadence and turnover, and you run very differently without a shoe than you would with a shoe. When you have a shoe on, when you have a shoe on, you can run, your heel can hit the ground. If you do that when you're running barefoot, it hurts.
Yeah.
So you end up turning over faster, landing more on the ball of your foot. You're a little bit more efficient. The problem is, although it's a great learning tool, it's a great drill, I would call it, if you did all your miles barefoot without a lot of great support, most of us wouldn't hold up. We would develop plantar fasciitis and other overuse issues.
So what is the attraction of running barefoot?
I think it's like the old, everything a little bit in moderation is okay, but I think it's attractive. One of the nice things about running outside is that you're in the elements and you're unencumbered, and not having shoes is a great feeling. But it's not sustainable, really, for most of us. Again, some people need a heavier, stable shoe, even with an orthotic in there, to prevent that overuse injury. So where there's a lot to learn, it's probably not for everybody.
I agree. Well, Dr. Spector, if our viewers have any questions, how can they reach you?
So I'm in Wheaton and Shady Grove. My office number, do you want it? It's 301-949-3668. And our website is under Foot and Ankle Specialist of the Mid-Atlantic. And I'm always happy to answer an email or call.
Thanks for joining us on House Call.
Thank you very much.
My thanks to Dr. Spector for an excellent interview. My thanks to my team here at the station. And thanks to you at home for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next topic, it's going to be a shift from podiatric medicine to pediatric medicine. My guest will be Dr. Alan Gober, a noted local pediatrician, and we'll be discussing the challenges of caring for children, and in particular, adolescent medicine. It's going to be a fascinating show. See you then next time for another edition of House Call. Good evening.